Good afternoon and good morning to you if you're on the West Coast. My name is Jose Leon, Chief Medical Officer for the National Center for Health and Public Housing. Such a great pleasure to moderate this session, session number 3. And it's been a great pleasure to collaborate with Southern AIDS Coalition and to present this webinar learning series. Before we get started and we hear from our subject matter expert this afternoon, just to remind you that we are the National Center for Health and Public Housing, and we provide training and technical assistance to community health center through a national cooperative agreement with the Health Resources and Services Administration, HRSA. We provide training to 107 public housing primary care grantees across the nation, and more than 886 health centers serving public housing residents around the nation, including Puerto Rico and Hawaii. This session is a live session. All lines are muted. We are going to have a Q&A at the end. So if you have any questions, you can either use the chat box and type your question, or use the raise hand icon and your line will be unmuted. There are around 2 million people living in public housing, and 38% of the population living in public housing are children. 59% of them are female, and 55% have less than high school diploma, and around 83% are at or below the federal poverty line. Again, there are 1,300 community health centers serving underserved and vulnerable populations. In the United States, there are around 380. This is the 356 that you see is for the 2017 data, and the latest data shows that it's 385 or 86 health centers serving public housing residents, and 107 of these 356 health centers receive funding from HRSA to provide services to over 100,000 patients across the nation. This is from the health picture of HUD-assisted adults, and this is a slide just showing some of the chronic medical condition affecting those living in public housing, including those who are smokers. That there is a HUD initiative prohibiting smoking in public housing, and there are other conditions such as diabetes, COPD, asthma, cardiovascular diseases that are more likely to affect those living in public housing. In regards to HIV in public housing primary care, we have around, this is 2017 data. This is taken from UDS, and the number of visits in 2017 for those with symptoms or without HIV, without symptoms, were over 13,000. And the health centers, the PHPC provided around 89,000 HIV tests in 2017. This is data in regards to those living or being served by public housing primary care grantees by sexual orientation. As you can see, the numbers probably do not reflect the population because of a stigma, because of privacy. Some patients don't want to disclose the sexual orientation. This is one of the reasons why I believe the topic that we are presenting and exploring through this webinar series is so important. And now it's my pleasure to introduce PJ Moton. He is a graduate, a 2013 graduate of Washington University's Brown School of Social Work in St. Louis, Missouri, where he earned his Master's of Social Work degree with a concentration in children, youth, and families. PJ is also a 2011 graduate of Fisk University in Nashville, Tennessee, where he earned a Bachelor of Arts degree in psychology and sociology. During his undergraduate studies, PJ discovered a strong passion for the work conducted by nonprofit organizations, and from there, he dedicated all of his time and efforts to serving underrepresented populations, which 11 strong years in the field of HIV/AIDS research, prevention, and care, specifically focusing on Black populations, PJ has become recognized as a leader among the millennial generation of game changers with regards to the epidemic. He was recognized as one of the National Black Justice Coalition 2015 inaugural cohort of top 100 LGBT leaders to watch. He was also a 2016 HIV 360 Fellowship recipient sponsored by Human Rights Campaign. PJ has a passion for philanthropy, social justice, and mitigation health inequalities. This passion, combined with his experience in both grant writing and grant making, has afforded him the ability to identify the needs of underserved communities and underfunded organizations. His goal is to strategically increase nonprofit sustainability in these communities. PJ has a successful award record for technical and foundational grant writing, while also designing and implementing fundraising initiatives. Without further ado, I'm turning it over to PJ. Good afternoon, PJ.
Good afternoon. Thank you so much. It's a pleasure to be with everyone today as the facilitator of this particular presentation, which is near and dear to my heart because not only is it the community in which I represent, but it is the community that I've worked for the past 11 years. And so while I consider myself a subject matter expert of this community and how other communities and practitioners can interact, I also consider myself a student of this community as I'm learning and growing each day. With regards to how to better engage and serve my particular community. And so today's presentation is titled Exploring Cultural Competence and Humility in the Care of not HIV patients, but Black, gay, bisexual, queer, and same-gender loving men. And we'll talk more about why I changed the title of the presentation. I know that it's a series and it's related to HIV care in particular, but it starts with language, and that's one of the things that we want to talk about here today. Next slide. So we're going to start with this video that kind of level sets the conversation for today. Go ahead. I'm having a problem hearing the sound. I'm not sure if everybody else can hear it or not, but I wasn't getting sound with that video.
We have some technical difficulties. Peter, can you please try to play from Explorer or the other browser?
Sure, 1 second.
Who said that? The lady at the store.
That is not a compliment.
Listen.
Is everybody else able to hear the sound? Because it stopped working for me again.
No, I can't hear it either. And so
It's fine. We can power past it. I can give you guys a synopsis of what the video talked about in particular. If we want to move on to the next slide. So the talk was a conversation. If you guys have the opportunity, you can look it up on YouTube. The talk was a video made by Procter & Gamble, and it gave an opportunity for individuals to really explore what it means to be Black in the United States, specifically as it relates to youth, and the conversations that parents are almost at a certain point required to have with their young people for the sake of almost survival sometimes. So the truth of the matter is that for some communities, it's not about, it's less important about who you are, and it's more important about how the world sees you. And it's unfortunate that things are shaped in that way, but that's what we're going to talk about a little bit more today. Society has shown us that time and time again that conversations like the one shown in this video are vital and necessary for some communities for survival, even at some point. Today, we're going to talk about a community that is marginalized, even within a marginalized community, and that is Black, gay, bisexual, queer, and same-gender loving men, and how this unique positioning puts them at risk for contracting HIV, higher rates of STDs, as well as falling out of care as we talk about the HIV care cascade. So welcome to the conversation. I wanted to highlight this particular quote from Essex Hempfield, and it says that the Black homosexual is hard pressing to gain audience amongst his heterosexual brothers, even if he is more talented, he is inhibited by his silence or his admissions. And that's almost like, if you've ever heard the saying, it's kind of a catch-22. You're kind of against the grain if you do, and you're kind of against the grain if you don't. And so we'll talk a little bit more about what that looks like and what that how that shapes the lives of Black gay men. You can move on to the next slide. Before we get started, I wanted to give an opportunity or to thank Southern AIDS Coalition for this opportunity to partner, being sponsored in part by Gilead Sciences through the Competence initiative. You can move on to the next slide. So my name is PJ Moton-Poole. I am just going to give a context of who I am. I am a father, I'm a son, I'm a brother, and I'm a husband. I bring those things to light because one of the things that we find in our community, that is the Black, gay, bisexual, queer, and same-gender loving men community, is that we often don't find these examples of how diverse our community can actually look, feel, and experience the world. And so I wanted to kind of talk a little bit about myself. And another fun fact about myself is I've been nominated for a Grammy, and I'm happy to share more about that at the end of the presentation, but I want to make sure that we get through some of this important information. I'm a principal consultant with Indigo Alchemy Services, LLC, and I've worked in HIV prevention, care, treatment, and philanthropy for over 11 years now. You can move on to the next slide. Hopefully, could we try this one? If not, then we'll go ahead and power through it as well.
Sure, I can go ahead.
And I'm happy to provide the URLs for these videos if you guys want to watch them later on your own time outside of the webinar. Yeah, it looks like we're experiencing the same issue with this one. So I'll talk through a little bit. So this is one of Dr. Maya Angelou's more famous poems, and this talks about an experience that she had with the woman on the bus, and she saw the woman every day, and the woman had a smile on her face, or what Dr. Angelou perceived as a smile. But what she came to realize is that the lady, after she had a conversation with her, said that this is the smile that grins, and that it's ultimately talking about the idea of Black communities having to, for the sake of the resilience that they possess and survival through the things that they experience, having to grin and smile through those pains and troubles just as a method of survival to get through. And so you can go on to the next slide. And this experience is not limited to Black communities, but when you think about the lives of Black gay men who are marginalized on each end of their existence, it kind of gives you an idea of what those troubles even look like, even from a deeper perspective. So the objectives for today's presentation are to introduce and name factors that shape individual identity, to explore cultural concepts including harmful impacts of toxic masculinity, DL culture, interpersonal relationships, and intersectionality. to examine and acknowledge where interpersonal dynamics of identity comes to impact healthcare for GBQSLG men of color living with HIV, and also to define cultural competence and humility. To my understanding from this series, you have heard several perspectives of how we are defining this idea of cultural competence and cultural humility. And so we're going to take an even deeper dive today and look at another perspective as to how we define and engage these concepts. We'll describe the intersectional impact of the social determinants of health, identity, and cultural competence on access, use, and trust in the healthcare system, and then develop or talk about tactical strategies for engaging GBQSLG men of color using a culturally responsive communication strategy and culturally informed base of knowledge. We can move on to the next slide. So this idea of personal identity, we understand is kind of like what I like to call a stacked Oreo perspective. It is a culmination of many parts of our lives that we see and don't see, some things that we control and some things that we do not control. So that is our biology. That is the idea that that we are genetically born and we are genetically acquire some parts of who we are that we cannot change. Our culture is shaped by the things that we are taught and the things that we're engaged in, the environments in which we grow up in, and how that shapes how we see the world, not only seeing the world through our own eyes and seeing ourselves, but seeing others through our eyes and how we perceive other cultures and other groups of people. Our ethnicity, which is the shared idea of human behavior and aspects and cultures and traditions, and then of course our lived experience. All of these things sandwiched together create what we call our perspective, or what we call our identity. Sorry, not our perspective, what we call our identity. And our identity shapes the way that we see the world and engage with other people. The problem with shaping our personal identity is that we often find ourselves having blind spots where we haven't experienced certain cultures, we haven't heard certain verbiage, we hadn't experienced or we hadn't had certain life experiences that enrich our ability to relate to and communicate with other cultures, identities, and populations. We can move on to the next slide. This is another slide that you guys have seen before, and so we're talking about perception, where we land. We land from a place of perception, and our perception is oftentimes limited based off what we've seen and experienced or even been taught. And sometimes our perception is based off of what we've been taught, which is also misinformed by what others have learned. And so our world is shaped by these perceptions, this perception of who we are, what we've learned, experienced, and what we've been taught. These implicit biases are nothing to be ashamed of, but we do have an innate responsibility to recognize that those blind spots, and implement a sense of course correction or an internalized kind of moral compass to keep us in a place where we're minimizing the harm to others that we might intentionally or sometimes unintentionally cause based off our limited understanding and perspectives. And so the fact of the matter is, you see someone and they are who they are, but you see them who they are, and that seeing them is based off the limited lens that you have, and that's what creates what we are in between, which is our perception of that person. We can move on to the next slide. So Black gay men have historically been on the forefront of shaping their own individual identity, but oftentimes this has kind of not been met with the same acceptance as other communities, and therefore it's kind of been a hidden culture where these movers and shakers have really shaped culture but not been able to be on the forefront or be in the limelight of owning those ideas and identities. And so this picture here is a picture of 3 historical figures in the Black gay community. And at the end of the presentation, if anybody knows who any of these people are, I would definitely love for you to share But what oftentimes I talk about that we've been doing this work for quite some time, and we've been living these lives and owning our own personal identity for quite some time, but it hadn't necessarily been in the limelight and recognized as others. So we have here Joseph Beam, who was a poet, a writer, and he is kind of seen as the father of Black mental health. He talked a lot about his experiences with depression, anxiety, and how that shaped the world in which he saw it and lived, and others like him. In the middle, we have Marlon Riggs, who was a writer, author, and filmmaker. If anybody has ever seen Tongues Untied, it's a great historical perspective of the kind of like art and culture of Black gay men and how the HIV epidemic has had an impact on that community. And then we have here, of course, Bayard Rustin, who was the right-hand man to Dr. Martin Luther King. He was one of the organizers of the March on Washington and one of the pioneers of the Civil Rights Movement. We can move on to the next slide. Here we have three additional historical figures. We have Mr. Langston Hughes, who was, of course, one of the fathers of the Harlem Renaissance and a great poet and writer. In the middle, we have Mr. Essex Hemphill. The beginning quote that I wrote or that I displayed was from Mr. Essex Hemphill, who was a writer, poet, and oftentimes talked about the experiences and expressions of Black, gay, bisexual, queer, and same-gender loving men. And then over on the right-hand side of my screen, we have Mr. Alvin Ailey, which most of us know as a prolific dancer and artist who really shaped the world of dance, and even today kind of does that shaping. You can move on to the next slide. So Black gay men are a diverse community of individuals. It's important to understand that while this whole idea of maleness and masculinity has plagued many cultures, it's definitely had an impact on Black gay men. It's important to also understand that Black gay men have been these radical arts and activists throughout the history of time, whether we recognize who they are or not, or recognize how they have shaped the world. Here we have Mr. RuPaul, who has shaped the world of drag, not only for the Black community, but also for the drag community at large. And we definitely like to recognize his contributions on the wider or broader artistic historic culture. We can move on to the next slide. Of course, Mr. Billy Porter, who is one who has been in the game for some time now, but is just now reaching that limelight, has really shaped what theater and what music and movies are really coming to be. Mr. Billy Porter is, of course, the star of the FX show Pose now, but has been in music and theater and in the arts since the mid 80s. So he's another person that I like to bring to the limelight when we're talking about Black gay men and who they are. And it's important that we talk about these historical figures, because it goes to show that this community has largely been pioneers for quite some time, and this is not something new, but it's the lack of understanding for these cultures that have really positioned them to be kind of the ones who are carrying the burden of HIV today, because as we'll talk about later on in the presentation, this lack of one's ability to engage and communicate with these communities has really been a disservice. We can move on to the next slide. So here's another picture I'd like to display. This is Black gay men today who are really shaping culture, who are really shaping the world of HIV, who are really shaping the world of public health and arts activism and music and other areas. This whole idea of narrative shift is a work that we are doing today, or a method of work that we're engaging in today to really elevate the narratives of these individuals. We can move on to the next slide. One of the things that comes in the way of Black gay men really being able to step into the limelight of shaping the world is this idea of stigma. And stigma not only has an impact on Black gay men's ability to live their whole lives and be their whole selves, but it also has an impact on their ability to seek the help that they need and deserve. So stigma has had a persistent impact on the course of the epidemic. The challenge of stigma can be addressed through cultural competence and humility. And I like to always course correct that and say that the challenge of stigma can be, the work of of challenging stigma can be started through cultural competence and humility. And as we'll talk a little bit more, we'll understand that cultural humility and cultural competence is a ongoing work and process, and to identify it as a finite place is the first place that we misstep in engaging these communities. So, and then also stigma, the deeper our understanding of the challenge, the better equipped we are, and we will be to address it. We can move on to the next slide. So I mentioned earlier in the presentation that Black gay men find themselves in a unique position as it relates to their engagement with the world. You have the Black community on one side, whereas because of the deep religious roots of the Black community, as well as some other cultural nuances that challenge this idea of, or that people have the perception that challenges this idea of the strength of the Black family. One's gayness or one's queerness is not necessarily as widely accepted. But then you have the gay community, whereas Black gay men may try to identify with another part of the composite that is their identity. And then you have things like racism, classism, sexism, and all the other isms that really make it hard for individuals to kind of to mold and to find safety and find a space and a place in that community. And so you have Black gay men, Black gay, bisexual, queer, and same-gender loving men who are kind of stuck in this middle ground and really having to identify places of safety and spaces where they can be vulnerable and places where they can really envelop as full human beings. And that's, and it creates a place of isolation that oftentimes works to the disadvantage of this particular community. We can move on to the next slide. It's important to understand that how Black gay, bisexual, queer, and same-gender loving men kind of get to this place. You have the intersection of race, cultural norms, and sexuality, and some of the promoting factors as it relates to the increased risk or the negative outcomes are, low socioeconomic status, racial segregation. Once again, I mentioned this as it relates to Black gay men trying to infuse their identities or find place and find space in the larger gay community. Internalized homonegativity, which is what Black gay men experience within their own Black communities, and then stigma, of course. Some of the negative outcomes of that is why we're here and talking about this community today. The increased risk of HIV, increased risk of STD, increased condomless sex, increased poor mental health, and increased substance use. These things are ultimately become the norm almost. If you think about CDC's predictive statistic around Black gay men, 1 in 2 Black gay men by the age of 30 becoming HIV positive, that whole sense of that predictive statistic, from my opinion, fosters this idea of this learned hopelessness, and ultimately leads to some of these negative outcomes. But we do have protective factors in place, which I love that this particular diagram that outlines these protective factors, because it really gives you something to build on. It gives a strength-based perspective to build on for this community. And so that's kind of this innate resilience that Black gay men have as a result of their cultural upbringing, this racial centrality, and this idea of one's innate closeness to their race and really being able to envelop themselves in that in those cultural perspectives, and being rooted in some of the things that make them are who they are. And then informal and formal support networks, which we'll talk about here in a minute when we talk about chosen versus biological families. We can move on to the next slide. So one of the things that we oftentimes like to talk about as it relates to Black gay men is this idea of toxic masculinity and what it looks like and then what it ultimately causes. So this idea of men never being able to be a victim. We talk about this, and we've heard a lot more about this here recently as it relates to like sexual assault and the mere fact that men can be victims of sexual assault and what that has meant for men who have been victims of sexual assault in the past and not really been able to come forward with those claims because of this whole idea of toxic masculinity and the idea that men could never be a victim in that way. This whole idea of like being a man and what it means to be male, or what it means for this whole idea of manliness and the things that society deems as the things that compromise those, and how that has an impact on one's ability to really be his full self. Being subject to violence. Once again, that's this whole idea of men not being able to be victims. The initiations and rituals and traditions and initiations that have seen in some cultures and in some communities to be harmful, but men feeling pressured to, Black gay men feeling pressured to engage in them anyway, just to kind of deem themselves worthy of to fit into this male community, and I'll say specifically this Black male community, where we see this idea of toxic masculinity really really persistent. Emotional suppression, and we'll talk about that here in a second as well. Let's go on to the next slide, because I really wanted to talk a little bit about some of the dangers of toxic masculinity and how we kind of see them show up in the world. So this idea of extreme self-resilience and need to do everything on their own. And oftentimes this makes it less likely for men to seek treatment or reach out for help in times of need. We see this oftentimes in younger Black, gay, bisexual, and queer and same-gender loving men, whereas there may be an STD present, or maybe even an HIV seroconversion, but because of this idea that men don't necessarily, well, even when you think about the historical perspective of Black men not necessarily regularly visiting doctors, but what that means if one is raised in a household where that is not a norm, and his ability to then empower himself to seek any type of medical treatment or even information for that case for the sake of what stigma or discrimination he may experience because of any proximity or association with anything as it relates to HIV or our sexual health. The second one is this shame, disassociation, and avoidance of emotional expression. This whole idea around boys don't cry, and how this is seen consistently in Black families as it relates to young Black males, and how that works against their ability to really empower themselves around their own health and sexual health. Extreme aspiration for physical, sexual, intellectual domination, even at the expense of authenticity. Once again, thinking about young Black gay men and their the challenges that they already face with fitting into their peer groups, and then how that might then even play out even more as it relates to them, feeling one way and identifying themselves as one way, but not really being able to express that early enough to get the information that allows them to navigate their lifestyle in a safer way. Devaluation of opinions, bodies, and sense of self of women and feminine expressive people. And so this idea that any male who has more a more dominant feminine expression than that of a male with a more masculine expression is less than, or has or is not necessarily provided space to or not necessarily provided space to have opinions or have a sense of self. Oftentimes, the way that we in the larger community see how men treat women, and this whole idea of that male dominance is often at times seen as well in Black gay communities, whereas the more masculine presenting male is the dominant figure and should have the voice, whereas the feminine expressive male may not feel as empowered. And then this idea of condemning anything feminine with another man or equating that affection for being a male being attracted to another male, resulting in higher isolation, loneliness, and lack of social cohesion. And so this idea that a male loving on another male is in some type of way a taboo and should not be publicly expressed. And this goes outside of just this idea of, this goes outside of just the identity of Black, gay, bisexual, queer, and same-gender loving men, but this also talks about what that relationship between father and son looks like, and what the lack of the embrace and or affection, and how that then plays a part in how that young male is shaped and then ultimately seen in his self-worth and ability to be loved in larger society. Let's go on to the next slide. We're going to power through some of the rest of these because I want to make sure that I get through all of the information. This idea of DL culture and what it looks like in the Black, gay, bisexual, queer, and same-gender loving men community. A lot of times people see it as a tool of manipulation, or this idea that people want to have the best of both worlds, or I've heard a variety of things as it relates to DL culture. But oftentimes what we have to understand is there's always another perspective to it. And sometimes it's only a matter of safety, survival, and security. One might not be able to openly express his sexuality because of fear of isolation from family and loved ones, because of fear of isolation from friend groups, because of fear of isolation even within their living environments, and how that could compromise their safety in those particular environments. So it's important to understand that there's always another perspective to these things, and really to challenge ourselves to consistently take a step back before we cast our judgments and or engage communities in through our limited perspective of who they are. Let's move on to the next slide. So we're going to talk a little bit about interpersonal relationships. Let's move on to the next slide. As it relates to Black, gay, bisexual, queer, and same-gender loving men, interpersonal relationships are very important. So we have this idea of biological family versus chosen family. If any of you are familiar with the ball and house culture, you'll understand this a little bit more, which is more modernly displayed on the FXO pose. This has been kind of the saving grace for Black gay men for quite some time now. Whereas traditionally, Black families have not been able to accept their same gender-loving male members of their family. What this means when that safety, security, and familiar confidence comfort is compromised. Many times we find that these chosen families are the saving grace from keeping Black, gay, bisexual, queer, and same-gender loving men from sleeping on the streets, from going hungry, and oftentimes providing them with the necessary information and resources to protect them from HIV acquisition. And so it's important to understand that. And why this is important, particularly for practitioners, is that we find that we are so used to the traditional method of engaging communities, whereas an individual might be brought in for testing, a young individual might be brought in for testing to a facility, and the first thing that the practitioner then may ask for is like parental where's your parent, or where do you live, and oftentimes kind of like view that through the perspective of the traditional family system. But it's important to understand that oftentimes Black gay men don't have the safety, security, or even the luxury of having that traditional family system. And so there might be another Black gay man that brings a young man in to get tested. And when we ask about who his father is, and he then identifies the older male as his father, to really understand that as tried and true, and to be no different from what we find in the traditional family system. Let's move on to the next slide. Another thing that is important, or that I like to talk about as it relates to mitigating risk for Black, gay, bisexual, queer, and same-gender loving men, is this idea of the concentration of HIV within our community, and we find ourselves navigating relationship dynamics, whereas this idea, or this consistent fear of HIV acquisition for those who are not living with HIV, and how that dynamic plays out, particularly between age demographics. So the power dynamic as it relates to older Black gay men having a dating pool of younger Black gay men, and oftentimes I hear this this misconception that older Black gay men who are living with HIV prey on younger Black gay men, and this idea of almost an unintentional narrative that is being created of like this intentional seroconversion of young Black gay men, and the burden of that being on older Black gay men. But the truth of the matter is, we're such a close-knit community, and it's such a closed community that I often find myself kind of in the position where I'm trying to explain to my peers or my colleagues that my work pool, the people who I work with, who are oftentimes Black gay men, are the same as my dating pool and the same as my social pool. And so to navigate the dynamics of those relationships, and to create those boundaries is oftentimes complex. And the thing that we don't do a good job of is sharing with young Black gay men how to navigate those dynamics, and how to navigate the dynamics of the social and romantic dynamics of the different communities in which we engage. We can move on to the next slide. And so the truth of the matter is, our community is many men, many faces, many voices, and many choices. And this is seen here once again as we talk about, in this picture here, we have social entrepreneurs, we have heads of state and federal departments, we have people who have worked in presidential campaigns, CNN commentators. It's such a huge and diverse community, and so it's important not to limit our perspectives to one way or one one way in which we see individuals who belong to this community. Let's move on to the next slide. We talked a little bit about this a little earlier, this whole idea of social economic.
PJ, I think we lost your sound a little bit. Can you hear me? I'm so sorry. We apologize for the technical difficulties right now. Just give us 1 minute.
Can you guys hear me now?
Yes, I can hear you now.
Okay, perfect. Sorry about that. I'm not sure what happened. Everything just blacked out. So I was talking about intersectionality, and so this idea that, or this concept where we find that all of the parts of who we are. That's our gender, education, sexual orientation, socioeconomic status, experiences. All of these things culminate our experiences and culminate the fullness of who we are as an individual. Let's move on to the next slide. And so as it relates to Black gay men and HIV, we find ourselves with some of the historical barriers as it relates to how we engage this community. But one of the common misconceptions that we have around Black gay men is that we put all these resources and time into education and into visibility. And true enough, we have done a great job of turning the tide of what that looks like today. But one of the things that we have not, in my opinion, put enough emphasis in is this whole idea of health literacy and making sure that we are engaging Black gay men in a way that makes them feel valued, makes them feel heard, and also making sure that they understand their options as it relates to treatment, that they understand what HIV does or can do to their body, and how to protect themselves, and not understanding it just by talking at them, but talking to them and understanding how these things fit into the cultural nuances and dynamics of who they are as whole individuals. Let's move on to the next slide. So this idea of health literacy is a culmination of what those conversations look like, what that written information looks like, what that conversation with the physician looks like, and one's practice as it relates to medical adherence, or as it relates to adherence to any type of behavioral practices, what all of those things look like in culmination with a person in the fullness of their lived experiences. And so if I am a practitioner and I prescribe an HIV medication to a young Black gay man, but I don't know what his housing status is, or I don't know what his schedule is as it relates to when he's able to have access to food, or if I don't know what his ability to access medical treatment in the case of emergency, if I don't know those things, but I talk at him and I give him, or basically prescribe him, this regimen, and the regimen is of course more than just the actual prescription, but it is also the routine in which one takes the regimen, but I don't know those things, then I could be setting him up for failure. For instance, if I am engaging a young Black gay man and I do not understand that he does not have an actual mailing address, but I sign him up for mail order prescriptions, then I ultimately have set him up for failure. If I don't know that he has access to food daily, but I prescribe him a medication that makes him sick, if he does not take it with food, then I'm ultimately setting him up for failure. And so this whole idea of health literacy is making sure that you, the practitioner, understands the fullness of who an individual is and how the medication might impact or how the treatment might impact them, but also making sure that they understand that and are providing you with that information as well. So next slide. So this idea of cultural humility is what I like to highlight. Again, cultural competence is this idea that is very abstract to me, and it really speaks to this idea of a finite place, as if I could read enough books or to research enough people and fully understand what it means to be a Black, gay, bisexual, queer, same-gender loving man, and that's just not true. So cultural humility is what we like to talk about, and it is a lifelong learning process and perspective which incorporates openness, self-awareness, power, balancing, and critical self-reflection to achieve mutually beneficial and respectful partnerships. Next slide. Cultural competence versus cultural humility. So humility is freedom from pride or arrogance as it relates to one's ability to learn, grow, and understand. And so that's constantly sitting on the cusp of this idea of what I like to call taking a step back. Like, where are my blind spots? Where am I? Where is my learning limited that might not be positioning me to hear what I need to hear or see what I need to hear in this situation? And examples of that are learning how to be situationally aware, learning how to ask for help, or I would even say learning how to ask in general. Coming from a place of inquiry oftentimes positions you to be in a place where people feel more empowered and open to tell you more about who they are and give you a well-rounded understanding of how to effectively serve them. Learning how to maintain curiosity and ask questions and reinforcing soft skills. Competence is the possession of sufficient knowledge or skills about a group, task, concept, or process. I can be competent in social work practice. I can be competent in making baking cupcakes, right? Like I can be competent in something that is a finite place. But this whole idea of learning who a person is, and people are ever evolving, ever changing, and how to effectively serve them is an ongoing work. And so it's not even important for us to go through the examples of competence, because that's not what we want to focus on here today. We want to focus on this idea of humility and what it means to constantly be in that ongoing work. Let's move on to the next slide. So the principles of cultural humility, if you really want to create change, are divided into three different levels. You have the organizational, you have the interpersonal, and the intrapersonal. Once again, a life learning process of critical reflection and self-critique. And then you move on to redressing the power imbalances in a patient-provider dynamic. And so that's your engagement, that's your interpersonal, that's your engagement with a person, and really being conscious about mitigating or being conscious about redressing that power imbalance, and how a client might see you as the provider of the information, the know-all in all, really breaking down those barriers. And then, of course, the intrapersonal is developing your own internal understanding of what your blind spots may be. I know we're coming down to time, so I want to power through the rest of these next parts. We can move on to the next slide. And these just break down what I just talked about with the intrapersonal, interpersonal, so you can move on to the next. And then the next. And then the next. I was just going to bring it back to the idea that stigma is another thing that really limits our ability to see a person. And so that's, whether we realize it or not, we become kind of the culprits of stigma and the people who sometimes, even when we don't realize it, we are creating stigmatizing environments for our clients or the people who we engage. I know this is probably not going to play, so we can probably move on to the next slide as well. But again, I will provide the URLs for all of these. And so when we talk about tactical strategies about how to engage these communities, it's about three parts of the process. It's making sure that the information is heard, making sure that the information is processed, and making sure that the information is understood. Let's move on to the next slide. The way that we make sure that this happens is, next slide. Oh, I'm sorry, teach-back method. Teach-back method is one method that we can use to make sure that this information is heard. And so it's important that when engaging Black gay men, the teach-back method is a tool that you use to engage these communities, to make sure that you start with the most important information of the message. You want to make sure that that information is the most important, and that you start there so that you can come back and make sure that the points are heard that are vital to your instructions as it relates to engaging this person, and not only engaging them in making sure that they understand what the information that you're providing to them, but making sure that they understand that you care. And so always focus it on 2 to 4 key points. And so for a newly diagnosed client, to give them a whole list of things that they have to do and be aware of, and diets they have to change and things of that nature, that might not be as well received, understood, or even may create a situation where an individual might already kind of like see themselves doomed as failed, because they might not be able to really adhere to all of these things. So really making sure that you break it down to plain language for them. And then also plain language and trying to avoid medical jargon. Let's move on to the next slide. Some of the communication strategies that I like to highlight particularly are this idea around like using plain language. So that is active voice, that is common words. One of the things that is a tool I like to use or I like to talk about is this idea of deep listening. Deep listening is when a client is talking to you and they, describe their body parts as using a certain word, but then you come back and use medical terminology to describe those body parts. It's kind of like, for me, is an example of not really doing a good job of deep listening and could create some type of language barrier as it relates to them and their ability to really understand the information that you're sharing with them. And then, of course, keeping it short, sticking to 1 to 3, no more than 4 points as it relates to the information that you're sharing so that you can make sure that the vital information is being processed. A positive tone, making sure that our tone is not very chastising or demeaning. Logical organization, so put the most important things first, and easy to read design features. And so if that means if you're passing out palm cards, if you're showing videos, if you're showing pictures and tables and things of that nature, making sure that it's easily understood. Not to assume that anybody has a certain level, literacy level, and can understand information as you present it. Next slide. And so the idea of how we really want to engage these communities is to understand that equality is one thing, but equity is the goal. But understanding that many times Black gay men don't have the power to determine which of these places that they end up. And so the idea is for the practitioner to really create this idea of liberation. Next slide. Where we are not focusing on making sure that we have equal services or promoting this idea of equality, but more so promoting this idea of equity. And then at times when you're able to really promote this idea of liberation, where there is no wall and there is no uneven playing ground for the people that you're serving. And to do that, it is important to make sure that you're understanding different cultures, you're understanding different perspectives, and you're understanding the nuances as it relates to these particular communities. Next slide. I think that's the last one too. I wanted to make some time for questions. Yes. And so sorry if I had to power through some of the last parts of that, but I did want to make sure that I got through the entire presentation and have time for questions. So if you want to share some of the questions with me, I'll do some quick responses before we end.
Thanks, BJ, for this this great presentation and the illustrative examples that you provided. This was really good, and I would like to apologize for the technical difficulties. The slides will be sent to all participants after the webinar is over, so you can have the slides and the videos if you want to go over the videos. So once again, this is a live event, and sometimes we have some technical difficulties. So I apologize for that. So let's see if we have some questions. In the meantime, I just want to remind everybody that we have one more session. This is going to take place on March 23rd, and it's going to be from 1 p.m. to 2 p.m. on March 23rd. Now, if you have questions, remember that you can either type your question in the question box, and then the chat box, I'm sorry, and your question will be read to our presenter. Or if you would like to ask a question live, you can use the raise hand icon and your line will be unmuted. Any questions, Fide?
Not at the moment, Dr. Neal.
All right. In the meantime, this is a reminder. This is an event, our national event. It will take place in Alexandria, Virginia, June 18th and 19th. Right now, we are in the call for abstracts process. So if you would like to submit an abstract, you can do it. You can go to our website, nchph.org, or you would like to register for the conference, you can also go to our website, nchph.org. You can also find a lot of information on our website, or you can sign up for HRSA updates, information on funding opportunity for health centers, information on senior programs, and other resources like past webinars, past publications, and past learning collaboratives.
Sorry to interrupt you, Dr. Leon. We have one question. And this question is from Nicole Chavez, and she says, it was a great point to discuss that the femininized attributes that attach to father-son dynamics. How do you navigate these or address this in Black communities?
I think one of the things that's important to do is to really understand that father-son dynamics are more than just a single person thing. And to understand that the importance of like the Black family unit, and so whatever that looks like. And so sometimes it means that in order to get the father's ear, you have to talk to the mother. And sometimes in order to get the father's ear, or to understand where challenges might exist in this relationship, you have to talk to the son about how to engage his father. And so it requires the empowerment of the different parts of the family to really engage a singular person, because the thing is, this idea of trust is not easily earned. And so if you can teach the people who are surrounding an individual who might be showing up as problematic in the family dynamic, if you can teach the people around them how to engage that person, then you find yourself kind of getting a better result, as opposed to trying to go to the father and ultimately what he might see is teach him how to be a better father. And so does that answer your question around tackling the father-son dynamics?
She said yes, thank you.
Okay, perfect.
Do you have any other questions today?
Not at the moment.
All right, I have a quick question, and you basically presented an excellent point, the toxic masculinity.
Mm-hmm.
And the question I have for you, if this is a concept or a phenomenon, I guess, that is also seen not only in male providers but in female providers, that particular way to see masculinity.
Yeah, I mean, toxic masculinity is something that plagues us as a human race in general, right? This whole idea of male dominance, and this whole idea that that men have the innate right to take up space, and therefore making less space for the more feminine expressed person and or woman. And so I see this in particular even with male providers who are more masculine presenting but have male clients, and who may be more feminine presenting, and kind of creating this culture or creating this space where they might not feel as empowered to talk about themselves in a way where they are the expert of their own lives and their own bodies. And oftentimes I've also seen that the male provider may not even be good at creating this space for the client. But as we talked about in the kind of some of the communication methods, this whole idea of being active about breaking down those power dynamics or power imbalances as it relates to you and your client is very important, because even whereas a more masculine presenting physician might not necessarily intentionally be kind of doing anything that fosters this idea of toxic masculinity, it still kind of creates that power imbalance. And so if you aren't actively on the cusp or on the forefront of addressing that, then it could cause more harm than good.
Excellent. Thank you, PJ. Any additional questions today?
None at the moment, Dr. Leon.
All right. This is just a reminder. Please complete the post survey. Your feedback is really important. They give us the opportunity to improve our activities. So if after this webinar, you will see the link to the survey, and please respond to the survey. Another question, PJ, and this is regarding health literacy.
Yes.
You discussed the teach back method, and how would you link this health literacy with the cultural humility? Do you think that health literacy is somehow affected if someone doesn't have cultural humility?
No, I think that it works hand in hand. I think that understanding a person as it relates to how they show up in the cultural nuances that they might present with will impact one's ability to kind of provide health literacy or to take the health literacy approach to engaging them. And so when I think about the different language that different communities use and how a physician might want to use the teach back method, but still is using like medical jargon, but that language is starkly different from the language that even the client that is presenting in front of them is using, and what that could and how that could work against them being able to provide really fully competent or fully culturally humble provide really culturally humble information and culturally informed information to their client. And another thing that I think about is this idea of some of the historical perspectives or the historical nuances as it relates to Black gay men that I presented today. If some people don't know about those things, including like the family dynamics, including the relationship dynamics, including some of the other information I shared, if a practitioner doesn't know about some of those things, then they really don't really know, have a baseline of information to know how Black gay men are showing up to their offices. And so it's important to kind of couple that health literate approach to this idea of cultural humility, to understand that there's always room for improvement and there's always some kind of this missing information, whether the practitioner recognizes it or not.
Thank you. Great response, PJ. Any other questions today in the queue?
No.
No questions? All right. I believe that we are very close to the hour. So just to remind people to visit our website again, you will find other training resources and information on our annual event. You can also contact any of our staff members in case you have any other questions. Thank you very much. I would like to especially thank PJ and Marcus and Southern AIDS Coalition for this excellent presentation. Thank you, everyone, and have a good afternoon.
Thank you.
Thank you.